The process of grieving can last anywhere from a week to an entire lifetime. We mourn everything from breakups and rejection to the deaths of our loved ones. Everyone deals with this emotion a bit differently. Grief is not a binary, but rather a spectrum. It can look different depending on the person's culture or upbringing, but it's one of those experiences that comes with being human. Recently, the American Psychiatric Association has recognized a different type of grief, the kind that lasts for years and has made a person incapable of moving on. This new diagnosis is called prolonged grief disorder.
There is a difference between what people ordinarily go through as part of the real grieving process and a small number of people. One of the research groups estimates it's perhaps 4% of people who have a loss of a loved one, which involves an extended grieving process that is marked not just by its duration, but by its intensity and by the fact that it has functional impact on the people involved.
That's Dr. Paul Applebaum, professor of psychiatry at Columbia University. He's the chair of the steering committee for the Diagnostic and Statistical Manual of Mental Disorders, known as the DSM. It's a publication by the American Psychiatric Association and is commonly referred to as psychiatry's Bible. The newly published DSM-5-TR includes the formal diagnosis of prolonged grief disorder. Applebaum says it applies only to a small group of people for whom the grief never ends. However, it can be diagnosed only a year after the grief begins.
The person must have experienced intense yearning and longing for the person and a preoccupation with thoughts or memories of that person. And that has to have occurred nearly every day for the last month prior to the diagnosis being made. So we're talking a year out now, and we're talking about still being preoccupied every day with the loss that was experienced.
Along with the 1-year threshold, the DSM lists 8 symptoms of prolonged grief, 3 of which are required for a diagnosis.
Identity disruption, a marked sense of disbelief about the death, avoidance, active avoidance by the person of reminders that the person has passed away, intense emotional pain, difficulty reintegrating into one's relationships and activities, emotional numbness, a feeling that life is meaningless, and intense loneliness. And again, as a whole, the duration and severity of this reaction must clearly exceed the expected social, cultural, or religious norms for the person's culture or social context, recognizing that those norms are different across different cultures.
Prolonged grief has been studied for decades, but there's never been a formal diagnosis until now. Dr. Holly Prigerson is one of the pioneers of the research. She's a professor of geriatrics in the Weill Department of Medicine at Cornell University. During a study looking at depression medication, Prigerson noticed the medicine helped the participants' depression symptoms, but their grief measurements were still elevated.
When I noticed that, they said, oh, that's okay. Our primary outcome in our trial is depression, and we're very satisfied with how helpful this is for treating depression. And I said, well, but it's not touching their grief symptoms. And they said, that's okay. Grief is the normal, natural response to loss and not an indication for treatment. And I said, well, how do you know? How do you know that it's not associated with possibly even worse outcomes than bereavement-related depression or anxiety? And they said, well, you can go study that. So I said, okay, I will.
And what she found is that there are distinct differences between grief and depression, just like the variations between anxiety and depression. But Prigerson says symptoms of grief can actually point to something much worse than the other disorders.
What we found was that these symptoms of grief predicted significant increases in suicidality and was a stronger predictor of suicidality even than bereavement-related depression or anxiety. The symptoms, not only did they predict the suicidal ideation, but they predicted heart attacks, hospitalization for things like heart attacks and accidents, It predicted before incident or new cases of cancer were all in the people who were high on these seemingly benign symptoms.
Although the symptoms vary from those of depression, they're similar enough to be treated as such. Prigerson says the issue is that people with prolonged grief won't find any relief using antidepressants.
If left alone and without intervention, they're unlikely to go away. And people are going to be distressed and sad and spend a lot of their life just feeling kind of miserable and forlorn when that doesn't have to be the case.
But even with prolonged grief disorder now officially in the DSM, the decision's being criticized by people like Dr. Joanne Cacciatore. She's an associate professor in the School of Social Work at Arizona State University and an expert on traumatic loss. Cacciatore thinks all grief is a part of life, and the official diagnosis unfairly targets people dealing with a traumatic loss.
It's important to me, first and foremost, because I'm a grieving mother. And my own child died 27 and a half years ago. And I know what grief looks like because I've been through it, what catastrophic loss looks like because I've been through it. But I don't think that telling a grieving person that they're the one who's disordered is the answer. I think telling society collectively we have grief and griever avoidant disorder. I can get on board with that.
Part of her concern comes from the diagnostic criteria, particularly using only 1 year as the marker to label these symptoms as extreme.
I mean, for somebody whose child died or whose very, very close partner died or a very close sibling died, yeah, life can feel meaningless even after a year. I honestly don't know very many parents who would say that after 1 year they would stop yearning for their child who died.
Cacciatore says for people who've experienced a big loss, it's often unrealistic to assume they'll regain their sense of identity after a year.
So I work with a beautiful grieving mom who worked for years using IVF to obtain her son, to get her son. She finally got him and was absolutely in love because she tried so many years to get him. And her, what we would call in research, importance of motherhood is very high. And then when he was 3 years old, he died during a routine scan. And I don't know how she's supposed to experience anything other than a loss of identity. First of all, he's her only child. Her importance of motherhood is very, very high. And then he dies. She didn't just lose her son, she lost her motherhood. People don't look at her as a mother anymore. And as it goes in the criteria, the loss of identity, quote, feeling part of oneself has died. Well, it has. Part of oneself has died. And so you can see where I have some issues with the criteria that have been set.
But Applebaum says just hitting the 1 year mark doesn't automatically merit a diagnosis.
It is not the case that anybody who at a year is still experiencing some signs of grief has prolonged grief disorder. We all know, at least all of us who've lost loved ones know, that one never forgets the people who are gone. One, in a sense, never gets over their loss, but one is also not crippled by that loss. This is not just a perpetually sad person who just isn't going to get over the loss that they experience, but this is somebody who has a disorder and a treatable disorder.
And one that's had decades of research. Applebaum says the 8 symptoms are the product of multiple global investigations by 2 major research groups.
Sometimes people think that psychiatric diagnoses are formulated around a table in a smoke-filled room by people horse trading. Well, I'll give you this symptom if you give me that symptom. But that's not the way it works. It's a highly data-driven process. And I think prolonged grief disorder exemplifies that.
Prigerson says this diagnosis is intended to get people the help they need. Treatment options for prolonged grief include building a stronger network of support and understanding.
It's not just any old support group will do. We have this notion of being a simpatico, similar like others who share the same type of loss. People share and feel more support and empathy from people who have the same, for example, mothers of drunk drivers, and that they understand each other better than widows of Alzheimer's patients. So in terms of having a like loss other and people who might have the same interests as well, we think that interventions that enhance your likelihood of meeting and talking and sharing with people with similar losses and similar interests might be a way of you gaining some sense of meaning from what happened and camaraderie, as well as feeling less isolated and alone, feeling more socially supported, and also enjoying yourself and finding new meaning in your life.
She thinks most of the controversy surrounding the diagnosis comes from the idea that it's blaming people for grieving. However, Prigerson says the goal is to give people more options out of the intense cycle of grief that they're stuck in.
We're saying if you meet criteria for prolonged grief disorder, the 4% that do in normal circumstances of loss, you are at risk for being suicidal. You are at risk for having high blood pressure. You are at risk for having a heart attack. You're at risk for cancer. That we've established that 4% is at risk for bad mental and physical health outcomes. And that's not pathologizing, that's pathology. We're describing the data. We're not blaming anyone.
You can find more information about Doctors Paul Applebaum, Holly Prigerson, Joanne Cacciatore, and all of our guests at our website, radiohealthjournal.org. Our writer-producer is Kristen Farah. I'm Reed Pence. Coming up next week on Radio Health Journal.
It used to be that patients with tetralogy of flow, not all of them survive to adulthood, but now the expectation is that most or all will live to be adults.
The incredible story behind a life-saving surgery.
Then, can you trust your online pharmacy?
I think the biggest misconception about counterfeit or falsified medicine is that it's not a problem in America.
All that and more on Radio Health Journal.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
There are people that you can reach out to cold and say, hey, I see that you talk about becoming a teacher. I'm thinking about becoming a teacher. Could I get a 15-minute virtual coffee with you? I have some questions I want to ask.
The importance of mentorship. Then,
have been very stagnant, and they've withheld raises as well as just raising base pay.
How workers are standing up and demanding more. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station and subscribe and listen to shows anytime on Apple Podcasts and Google Play.
And that's Radio Health Journal for this week. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.